Hello everyone. Today's topic of discussion is on cephalometrics. These are the topics which will be covered today. So to start with, anthropometry is a measurement of dimensions of the human body and its parts, whereas craniometry is a branch of anthropometry dealing with measurements of dimensions and angles of bony skull. The cephalometry, which we will be talking on today, is a scientific measurement of dimensions of the living head. So a little bit of history. So the discovery of X-rays in 1895 by Sir William Conrad Röntgen was a breakthrough. In 1915, Van Loon of Holland developed a method for 3D registration of face and dentition. In 1931, Herbert Hofroth of Germany published a paper describing a technique to produce lateral cephalometric head plates. Simultaneously, Broadbent Hawley of Cleveland, Ohio, USA, published a new X-ray technique and its applications to orthodontia. So basically, cephalo means head and metric is measurement. And röntgenographic cephalometry, which we are using in ortho, is the measurement of head from the shadows of bony and soft tissue landmarks on the radiographic image. So the lateral cephalogram and frontal cephalogram. There are two main cephalometric radiographs. The lateral view is the lateral cephalogram and the frontal view is called as the PSF. So the one on the left is the lateral ceph and the one on the right is the PSF or the frontal view ceph. So Broadbent, he developed a device to stabilize and properly orient the patient's head. So it consisted of a head positioning device, a cephalostat, a film plane, a source plane, an X-ray source, an X-ray film in a cassette, and the mid-sagittal reference plane. So the patient's head was positioned in the cephalostat, and Broadbent, he standardized the source target distance of 5 feet from the anode to the mid-sagittal plane of the patient's head. And Hofroth used the same distance at 2 meters. So the ear rod which is present has to be inside the external auditory canals, and there should be a fixation which has to be made at the bridge of the nose and the forehead of the patient. The head has to be aligned such that the Frankfurt plane or the horizontal plane or the natural head position should be parallel to the floor. The teeth has to be in proper centric occlusion and the lips have to be in an habitual position. The cephalometric landmarks are divided into unilateral landmarks and bilateral landmarks. Unilateral landmarks are identified structures in the mid-sagittal plane, whereas bilateral landmarks are identified structures in both the right and left side of the head. The cephalometric landmarks can be further divided into anatomic and derived, and they can also be divided as hard tissue landmark and soft tissue landmark. Anatomic landmarks represent the actual anatomic landmark of the skull, whereas derived landmarks are ones which are obtained secondarily from the anatomical landmarks. So here are some of the basic landmarks. The first is the sella, which is the point S. It's a geometric center of the pituitary fossa. The second is the nasion or N point, which is the most anterior point on the frontonasal suture. The next is the porion, which is represented by PO. It is the most superior part on the external auditory meatus. The next is the ANS, which represents the anterior nasal spine, and it is the anterior tip of the sharp bony process of the maxilla. Next is the PNS, which is the posterior nasal spine, which is the posterior spine of the palatal bone, which is the continuity of the hard palate. Next is point A. Here it is represented by the letter A. This is the most superior midline point in the concavity between the ANS and the inferior point on the alveolar bone overlying the maxillary incisors. Similarly, the one which is overlying the mandibular incisors in the concavity near the chin is called as the point B, which is represented by alphabet B. Next, coming to pogonion. So this is the most anterior point on the chin. This one, which is represented by POG, is the most anterior point on the chin. Next is the gnathion, which is the GN, which is beneath the POG. It is located by taking the midpoint between the anterior and inferior parts of the bony chin. Next is the gonion, which is represented by the letter GO, which is located on the curvature of the angle of the mandible by bisecting the angle formed between two lines, which is one is tangent to the posterior ramus here and another is the inferior border of the mandible. So these two tangents are connected and it is marked as GO. So these are the basic landmarks which we will be needing for the analysis which we will see today. Next is cephalometric lines or planes. So this can be divided into horizontal lines and vertical lines. Horizontal lines or horizontal planes. The first one is the SN plane. So this is basically the cranial plane, which is connecting the center of the sella and the nasion, which is the SN plane. Next is the Frankfurt horizontal plane. This is the most commonly used reference plane. This is the common tangent to the upper external auditory meatus, that is the point polon which we saw before, and the inferior body of the orbital, which is marked by O. So these 2 points are connected to form the Frankfurt horizontal plane. Next is the mandibular plane. There are several different analysis which use different mandibular plane for reference. So the first one is going to be tangent to the lower border of the mandible. This is used in Tweets analysis. And in Downs analysis, the mandibular plane consists of the line connecting between the gonion and menton. In Steiner's analysis, this represents a line connecting the gonion and gnathium. So depending on the analysis, the mandibular plane will also slightly differ. Next is the palatal plane. This is just a line connecting the ANS and the PNS. Coming to the Bolton's plane, Basio-Nasion plane. This is a line connecting the Basion and the Nasion. Coming to the Bolton's plane, this plane connects the Bolton's point, which is posterior to the occipital condyles and the Nasion. So that is with the horizontal planes. Coming to the vertical planes, first is the apog line. So as the name suggests, it's a line connecting between point A and the pogonion. Coming to the facial plane, it is a line connecting the nasion to the pogonion. Now, starting with the analysis, the first analysis which we will be seeing today is the Downs analysis. And the reference plane which we will be using for Downs analysis is the FH plane or the Frankfurt horizontal plane. So this analysis was done based on the study of 25 white subjects who had good occlusion and proportional facial skeleton. This indicates whether the dysplasia, that is whether the problem is in facial skeleton, that is whether this is a skeletal problem or in the dentition, or it is a dental problem or a combination of both. So there are 10 parameters which are assessed in Downs analysis. 5 are going to be skeletal and 5 are going to be dental. So starting with the skeletal parameters, the first one which we will be seeing is the facial angle. So it is the angle formed by intersection of the nasion-pogonion plane, which is this NPOG, Nasion-Pogonion plane, and the FH plane. So the average value is 87.8 degrees, and the range is between 82 to 95 degrees. So this angle gives us an indication of the anteroposterior positioning of the mandible in relation to the cranial base. So if the value is increased, it means that the mandible is forward. For example, that is going to be in class 3 cases. Whereas if it is decreased, for example, then it is going to represent that the mandible is behind in the such in class 2 cases. Next is the angle of convexity. So this is formed between the intersection of a line from the nasion to point A and point A to pogonion. It's basically two lines, nasion to point A and from point A to pogonion. So this angle reveals the convexity or concavity of the skeletal profile. A positive angle or an increased angle shows a prominent maxillary base compared to the mandible or a retrognathic profile, while a negative or a decreased angle shows a prognathic profile. So the mean reading is going to be 0 degrees and the range is from minus 8.5 to plus 10 degrees. Next is the AB plane. So this is an angle formed between a line connecting point A and point B and a line connecting nasion and pogonion. So this angle which is going to be present is indicative of the maxillomandibular relationship in relation to the facial plane. It is usually negative as point B is usually behind point A. In case of class 3, a positive angle is going to be seen. So the mean reading is minus 4.6 degrees and the range is between 0 degrees to minus 9 degrees. Next is the FMA. This is very important. So this is formed by intersection of the mandibular plane with the Frankfurt horizontal plane. So an increased FMA means that the patient is a vertical grower or he has a very hyper-divergent facial pattern. So the mean reading is 21.9 degrees and the range is between 17 degrees to 28 degrees. Next is the Y or the growth axis. So this angle is formed by joining the sella and gnathion, this region, sella to gnathion with the FH plane. So this angle is larger for class 2 patterns than the class T patterns and indicates the growth pattern of the individual. So if the angle is going to be greater than normal, it shows that the patient is a vertical grower. Whereas if it is going to be lesser, it indicates that patient is a horizontal grower. The mean reading is 59.4 degrees and the range is between 53 degrees to 66 degrees. That is with the skeletal pattern. Coming to the dental patterns, first we are going to assess the cant of occlusal plane. So this angle is formed between the occlusal plane, which is constructed by bisecting the occlusion of first permanent molars and incisors and the FH plane. So this is going to tell us whether there's a cant of the occlusal planes. So this angle gives us a measure of the slope in relative to the FH plane. The mean reading is 9.3 degrees and the range is 1.5 degrees to 1.4 degrees. Next is the interincisal angle. So this angle is formed between the long axis of the upper incisors and long axis of the lower incisors. So this angle decreases in class 1 bimax. That is, it is going to be very much forward, the incisors. So in this case, the angle is going to be decreased. And in class 2 division 1 cases, whereas it is going to be increased in class 2 division 2, because in class 2 division 2 the upper incisors are going to be very upright and the lower incisors are going to be upright as well. So the angle is going to be very increased. The mean reading is 135.4 degrees and the range is between 130 degrees to 150 degrees. Next is the incisor mandibular plane angle. So this is formed by intersection of the long axis of the lower incisors with the mandibular plane. So the angle increase of this is going to tell us that the lower incisors are very proclined. The mean reading is 1.4 degrees and the range is between minus 8.5 degrees to 7 degrees. Next is the incisor occlusal plane angle. So the inside or the inferior angle formed by intersection between the long axis of the lower incisor and the occlusal plane. This is called as the incisor occlusal plane angle. It is read as a positive or a negative deviation from a right angle. So an increase in this is suggestive of an increased lower incisor proclination. The next one is the upper incisor to the ape log line. This is a linear measurement. That is, it is going to be measured in millimeters. The others were all in degrees. This is going to be a millimeter measurement. So it's a linear measurement between the incisal edge of the maxillary central incisor and a line joining the point A to the pogonion. So the average value is usually 2.7 mm and the range is minus 1 to 5 mm. So it is more in patients with upper incisor proclination. So when upper incisor are proclined, it's going to be forwardly placed. So the measurement is also going to be increased. So that is with the Downs analysis. Next, coming to the Steiner's analysis. This was developed in 1930 by Cecil C. Steiner, and this analysis aims at providing a maximal clinical information with the least number of measurements possible. So the Steiner's analysis is classified into skeletal analysis, dental analysis, and soft tissue analysis. Coming to the skeletal parameters, the first is what is called as the SNA angle. As the name suggests, this angle is going to be formed by the intersection of the SN plane with the line joining the nasion and point A. So this angle indicates the relative anteroposterior positioning of maxilla in relation to cranial base. So since the point A is in maxilla, it's going to relate the maxilla to the cranial base. A larger than normal value means that the maxilla is prognathic, while a smaller value indicates a retrognathic maxilla. So the mean reading is 82 degrees. Coming to SNB. So similarly, SNB is going to be the angle between SN plane and a line joining nasion to point B. So the point B is in the mandible. So this indicates the anteroposterior positioning of the mandible in relation to the cranial base. So an increase in angle indicates that it's a prognathic mandible and lesser value indicates that it's a retrognathic mandible. And the mean reading is going to be 80 degrees. Next is the occlusal plane angle. So it is formed between the occlusal plane and the SN plane. So the occlusal plane is represented by a line between the overlapping cusps of the first premolars and first molars. So this angle denotes the relation of the occlusal plane to the cranium, and the mean reading is 14 degrees. Coming to the A and B angle. So as the name suggests, the angle is formed by intersection of the lines joining nasion to point A and nasion to point B. It denotes the relative position of maxilla and mandible to each other. So it is connected with each other. It is not going to suggest anything regarding cranial base. It is just denoting the relationship between the maxilla and mandible to each other. So an increase is suggestive of class 2 skeletal tendency, while lesser than normal suggests a class 3 skeletal relationship. And the mean reading is going to be 2 degrees. Next is the mandibular plane angle. It is the angle formed between the mandibular plane and the ascent plane. So the mandibular plane here, as we saw before in Steiner's analysis, the mandibular plane here is a line connecting the gonion and gnathion. So this angle indicates the growth pattern. A lower angle suggests a horizontal growing phase, and the increased angle shows a vertical pattern. That is with the skeletal parameters. Now coming to the dental parameters, the upper incisor to NA angle. So this is formed by intersection of the long axis of the central incisors and a line joining nasion and point A. So this angle is the upper incisor to NA angle. The mean is 22 degrees and it indicates the relative inclination of the upper incisors. So an increased angle is seen in case of severe proclination. Next is the lower incisor to NB angle. Similarly, this is formed between NB plane and lower incisor long axis. And the mean value is 25 degrees. It shows us the inclination of lower central incisor. An increased value shows a proclined lower incisor and a decreased angle gives a retroclined lower incisor. Next is the upper incisor to NA, which is a linear measurement. The one we saw before was the angular measurement. This is a linear measurement. So it is a linear measurement formed between labial surface of the upper central incisor and a line joining the nasion with point A. So the mean value is going to be 4 mm. This value helps in determining the upper incisor position. So it increases in case of proclined upper incisors. Similarly for the lower incisors, we are going to check with the NB plane. So it is a linear distance between the labial surface of lower central incisor and a line joining nasion to point B. The mean value is going to be 4 mm. And it helps us to assess lower incisor inclination. Increased values show proclination and the vice versa also. Next is the interincisal angle. So as the name suggests, it is going to be between long axis of upper central and the long axis of the lower central incisors. The mean value is 130 to 131 degrees. A decreased angle is seen in proclination of incisors and an increase in angle is seen in retroclined incisors. Coming to the soft tissue analysis, Steiner suggested something called as the S line. That is, in a well-balanced phase, the lips should touch the line extending from the soft tissue contour of the chin to the mandible of an S formed by lower border of the nose. So there is going to be an S-shaped pattern which is to be visualized. And in this S-shaped pattern, the lips are supposed to touch on the line which is the S line. If the lips are beyond this line, it indicates a protrusive lips and in convex profile. And if the line shows retrusive lips, then the patient has a concave profile. This can be seen in the image which is represented below. Now, Steiner's acceptable compromises. All malocclusions cannot be completed in an ideal inclination of the upper and the lower incisors. So, there should be some compromise which can be made. And hence, Steiner's has given these arrangements which are acceptable for the different types of malocclusions. Next, coming to Tweet's analysis, 3 planes are used for forming a diagnostic triangle. The first is the Frankfurt horizontal plane. Next is the mandibular plane and long axis of the mandibular incisors. Coming to the Frankfurt mandibular plane, it is formed by intersection of the FH plane with the mandibular plane, and the mean is to be 25 degrees. Next is the incisor mandibular plane angle or the IMPA. So this is formed by intersection of the long axis of lower incisor with the mandibular plane. So this indicates the inclination, proclination or retroclination of the lower incisor, and the mean value is going to be 90 degrees. Coming to the Frankfurt mandibular incisor angle, this angle is formed by intersection of long axis of the lower incisor with the FH plane, and this mean value is going to be 65 degrees. So basically it is a triangle and the sum of these triangles should be 180 degrees. So the FMA should be 25 degrees, the IMPA should be 90 degrees, and then FMIA should be 65 degrees. So when we calculate in an ideal patient, the sum of these angles should be 180 degrees. Next, coming to Witt's appraisal. So it is a measure of the extent to which the maxilla and mandible are related to each other in the anteroposterior plane or the sagittal plane. So it is used in cases where the A and B is considered not so reliable due to factors like the position of nasion cannot be established properly, or there's rotation of the jaws. Then in these conditions, we consider the Witt's appraisal. So here a functional occlusal plane is drawn through the overlapping cusps of the first premolars and the first molars, and perpendiculars are drawn to the occlusal plane from point A to point B and point B. The point of contact of these perpendiculars are termed as AO and BO, and the distance between this AO and BO gives us the anteroposterior relationship between the two jaws. So in case of males, the point B is going to be ahead of point A by 1 mm, while in females, the AO and BO are going to coincide with each other. So in case of a skeletal class 2 tendency, the BO is usually behind AO, whereas in class 3 cases, the BO is going to be ahead of AO, and it is read as a negative reading, that is minus how many ever mm is there, minus 4 mm or minus 6 mm, like that. So next, coming to errors in cephalometry. So there are a number of possible reasons which may creep in during cephalometry, because it involves lots of steps such as obtaining a good radiograph or use of geometric constructions and analysis and interpretation of the values which are obtained without any observer bias. So there can be a number of errors which can occur in cephalometry. So this is a table which tells us what are all the errors, what are all the causes, and how to minimize it. Next, coming to cephalometric superimpositions. So this basically involves the analysis of the same patient taken at different time intervals. So the main use of this is to evaluate the patient's growth pattern and to evaluate the changes produced by orthodontic and surgical procedures. So how it should be done is, so it should involve the like following things. Change to the overall face can be assessed. Change to the maxilla and maxillary dentition can be assessed. Changes to the mandible and the mandibular dentition can be assessed. The amount and direction of condylar growth and mandibular rotations also can be assessed. So how it is done is by superimposing the serial films on a stable registration point. The changes little during the growth period. So when a patient grows, we are going to take serial lateral cephalograms, and we are going to have a constant plane or a constant point. For example, the sella or the nasion or the SN plane. Like that, we are going to have some constant registration points, which usually has lesser development. And we are going to assess the development of the jaws by placing the cephalograms on these registered points. So here are some of the superimposition methods, and the reference planes used, as I told, was the Bolton-Nasion plane for Broadbent, Bayesian-Nasion plane by Ricketts, Sella-Nasion line in ABO 1990, and Bayesian horizontal plane Cohen. So first is the Bolton-Nasion plane by Broadbent in 1931. So this shows the downward and forward growth of the face from beneath the cranium. And the reference plane here, as suggested by the name, is the Bolton-Nasion plane. And there's something called as the R point or the registration point, which is the midpoint of the perpendicular from S to the Bolton plane. So this is the registration point or the R point, and the serial radiographs are going to be taken and superimposed by coinciding Bolton-Nasion plane. Next is the Sella-Nasion line by ABO 1990. So two cephalograms are oriented on the Sella-Nasion line. The registration point is the Sella, and it is accurate as long as the growth at the nasion is a linear extension of the Sella-Nasion line. That is, the angle should not change. As long as there's only an increase in length of the nasion and Sella, this can be used as a reference plane. Coming to Bayesian horizontal by Cohen in 1986. So this uses a Bayesian horizontal constructed at the level of anterior border of foramen magnum parallel to the FH plane. And the registration point used here is the Bayesian. Next is the Bayesian-Nasion plane by Ricketts in 1979. So this forms a baseline for growth analysis. And the reference point here is the Bayesian-Nasion plane. And the reference point here is something called as the CC point, which is located here, which is the point of intersection between the Bayesian-Nasion plane and the Ricketts facial axis. Coming to maxillary superimposition, so it is basically done to determine the amount or the amount of movement of the maxillary teeth in relation to the basal part of the maxilla. So the methods include superimposition along the palatal plane using ANS as reference point, or superimposition on the nasal floor and registering at the anterior surface of maxilla, or it can be used along the palatal plane using the pterygomaxillary fissure as registration point, or on the best fit of the internal palatal sutures, or on the outline of the infratemporal fossa and posterior part of the hard palate. Coming to the mandibular superimpositions, it is done to determine the movement of the mandibular teeth in relation to the basal part of the mandible. So it can be registered at lower border of mandible, or it can be constructed mandibular plane between the menton and gonion, or it can be an anterior contour of the chin or inner contour of cortical plate at inferior border of symphysis, or it can be the contour of the mandibular canal posteriorly and lower contours of mineralized molar tooth jobs. So this is regarding the cephalometry, but there are lots of problems and limitations for cephalometry as well. First thing is, it is a two-dimensional representation of a three-dimensional structure. So there can be overlapping subjects and there can be improper landmark registrations also. And problems in orientation of the patient while procuring radiograph, like maintaining the head position, or there can be false precision, that is difficulty in locating the landmarks precisely, or fallacy of ignoring the patient, the mean population which they have taken in order to determine the average values are different for different races. So the population bias can also occur. Or there can be fallacy of using chronological age for comparison and reference with different age classes. So to conclude, the validity and reliability of single cephalometric measurements or group of measurements in a description of craniofacial and dental variation are often questionable. So each analysis has its own advantage as well as disadvantage, and orthodontic diagnosis must be based on a comprehensive individual evaluation of each patient. And the limitations as well as advantages of the cephalometry must also be recognized and used wisely. So thank you.